All right, good evening, everybody. I'm Jim Kohner. I am your presenter for this evening, and we're talking about crown lengthening, probably one of my most popular topics during the lectures and workshops that I've been doing over the years. I'm honored to be here with you, and I'm glad that you're here with me as well. I'm told by the people that run this thing, Desiree, to share this start code with you and that you should write it down. Oh, I probably took that away too fast, didn't I? There we go. So you should write that down. Okay, there'll be an ending code, but you probably all know better than I. So this is me, Jim Kohner, periodontist out of Denver. And you can see the beautiful snowy Denver. We had 18 inches last weekend. And today there's almost no snow left, 55 degrees and sunny. That's Denver weather for you. So we're going to talk about the topic of crown lengthening and how it can help you, restorative dentists, get better restorative results. So with that thought in mind, I don't know, if you have something to write on or with, I have something for you to write down to kind of set the tone for the evening. I want you to write bone to restorative margin. And when we do these live, people are saying, oh, I need to borrow a pen. It's so funny, people come without a pen. Bone to restorative margin, or CEJ. What you've just done, if you humored me and wrote it down, I don't have any way of knowing that you did. You've just written down the essence of tonight's presentation. And as one of our biblical sages supposedly said back in the day, all the rest is commentary. So we're going to have some commentary for an hour, but you just wrote down the key, bone to restorative margin. Tonight, I want to share with you a couple of concepts. We have an hour. How many concepts can I share with you in an hour? So we're going to not be looking at teaching technique. If any of you are doing these procedures yourself in the office already, we're not going to work on your technique. We're going to talk about concepts that you can use immediately. 2 concepts, not bad for an hour. Save more teeth. I mean, as the slide says, it's the age of titanium. This is crazy what's going on today. There's too many teeth being taken out that I and others in the field think could be saved, if not easily, maybe with a little effort. Save more teeth, that's number 1. So we're going to try to evaluate tonight. Are these teeth really hopeless? They may look hopeless. And I'm going to show you teeth that you say, well, yeah, they look pretty bad, that actually turn out looking to be pretty good. We're going to look at the radiographs, and we're going to learn that the radiographs can also provide a lot of information without even needing to do an oral exam. So those are my 2 points. Hopefully you'll have a new perspective on the radiographs and potentially a new perspective on my pet peeve, saving more teeth. So with that in mind about saving more teeth, I want to share with you a little bit from an article. It was really a 1-page editorial that appeared in Journal of Dental Research 5 or 6 years ago, just 1 page, and these are the 2 editors that wrote it. Let me just share a couple sentences from their article. They say that a trend affecting clinical practice over the last 2 decades has been the reduced emphasis to save compromised teeth. They have that in quotes, save compromised teeth. As such, they go on to say, many teeth are being condemned at early stages given the expediency that lends itself to just take out the tooth and do an implant. Then they go on to say the erroneous belief, and that's their words, not mine, of implants yielding a better long-term prognosis has now clearly been rejected in several studies and reviews. And on the second page is 12 or 15 reviews. And this was 5 or 6 years ago. I've seen many more since that point out the fact that we are not seeing the result, the high percentage of results that we were told we would see with success for implants. It's really lower over the years. And then they conclude by saying teeth, even compromised because of perio or endo, may have a longevity that surpasses by far that of the average implant. Well, I know I'm talking to the choir because you're all here with me tonight, But the point is, I think that in our field, too many teeth are being removed that don't have to be removed. Here's an example from a colleague, a periodontal colleague down in Florida, retired now, a colleague in Florida, Danny Melker, and he shows this, and I think you would agree that this tooth, if not both of them, looks a little challenging to restore and have any retentiveness for a crown. But you can see here, after shortening the gum, which also involves modifying the bone, that he's able to create healthy, sound tooth structure, even with a buildup, even with a good size buildup, to make this challenging, if not impossible, tooth to restore, restorable. So it's not just me talking about these things. There's other people out there. So I am concerned a little bit with the future of dentistry because I've had reason to find out what's going on in some dental schools. And frankly, it's titanium oriented, which is very upsetting. So look, for instance, at this illustration of a case from my dental school that was sent by a colleague who had been offering for free his services to teach a half day a week for 50 years. 50 years for free. They gave him free parking. I'm not exaggerating either. And he sent this out to some of us, and he said, what do you think? Is this tooth restorable? Because what happened was when he got to this patient in the clinic, the student had already been to another periodontist who said, extract 2 implants. And my friend said, this just doesn't seem right. He sent it to some of us. I said, I agree 100%. This is a no-brainer tooth for my crown lengthening program because there's not even any bone loss. There's no periodontal disease. The furcation's intact. It's just there's been some decay and lost tooth structure. We could easily make this totally restorable. If Danny Melker could make that other tooth restorable, this one's even easier. By taking away a little bone, shortening the gum, more tooth exposed. Kind of a no-brainer. And he said, I think this is the beginning of the end for me teaching at the school. I think it was. I've also been very privileged to have met a young lady when she was in her second year of dental school. And she asked me if I would do some mentoring for her. I had no idea what that was going to be about, but now she's a year and a half out of dental school. We're still in touch. I help her with cases, treatment planning, and whatnot. This illustration that you're looking at on the screen was her very first clinic case when she went into the clinic, her very first one. And she went to a faculty member and wanted to restore it. And he said, no, with this decay here down on the bone, you can't restore this tooth. She said, what about crown lengthening? And was told, no, that's only for the perio grad students. You know, your first case in the clinic going into her junior year, no, this is an implant case. Like that's easier than saving a tooth, right, Mr. Professor? So she got very upset because she had been, wait, I have to give you the background. She had been the moderator for many of these crown lengthening webinars that I do for another company. So she knew the topic. That's important to know. So she said to me, I really believe this is treatable. Well, the irony is that when she sent me the x-rays, it had other radiographs, including bite wings that showed a completely different picture. Look at this. I agree, right? The decay is on the bone. Look at this. The decay is nowhere near the bone. So they wouldn't let her do a crown lengthening. She had to do some kind of electrosurge, fudged it to get the gum out of the way. But she restored this tooth, her very first case, and she told me she saw the guy the week she was graduating, and it's doing fine. Now, she knows it's not a perfect crown. She knows that, but she saved it. This happened with her first 3 clinic cases. They all were supposedly implants. She saved every tooth. But she had me, her classmates, Titanium City. Now, look, I don't want you to think that I believe everything can and should be saved, that no implant should be done. No, I don't feel that way. Danny Melker also agrees some of these teeth have to be removed. Sometimes you need implants. He, on the other hand, never did an implant. He's very proud of that. If the patient needs one, he'll refer them elsewhere. So this is one that I did. I felt Susan in her mid-50s. A bridge had rotted out underneath the distal abutment. that this tooth was pretty challenging. If we took away a little bone to give us 5 millimeters of tooth structure, 3 for feral, 2 for biologic width, we'd be down here almost to the end of the root. So I felt, no, this was not a good tooth to save. Plus the wisdom tooth is right here. We took them out and she did the implants. So I'm not anti-titanium, and I want to be sure to clarify that because it's really easy to misinterpret what I'm saying. I believe that these procedures that we're talking about have tremendous benefit for you as restorative dentists to solve restorative and aesthetic situations. And I'll try to show you some of those examples tonight. All right, here's an example of a young guy in his 30s. That's young, right? Young guy in his 30s, he's having the bridge redone already because sensitivity and open margins. So here's my question. Do you think that you could get good impressions of any of these teeth, even if you did one tooth at a time? Could you do one tooth at a time? Still would be challenging to find the finish line and get a good impression. And here's an example of a nice impression from my friend Tom Piccolo, who, by the way, did like 6 or 8 different weeks down at Pankey, and we had a great time working together because I had the Pankey background as well. So here's a nice finish line. Could you do that on Brad? No, I don't think so. On the other hand, after shortening the gum, contouring some bone to get the gum out of the way, now you can go ahead and re-prepare. Put your margins wherever you want. You want them subgingival, supragingival, at the gingiva? You can do that because you have control over the tissue in the teeth. Even if you're doing digital impressions, whether you're doing the gooey impression or the digital impression, you still have to see the tooth and you still have to see your margins. Here's another restorative challenge with provisionals falling off. Robin is a young lady, also in her 30s, and she's ready to get some dentistry done. She's had a lot of problems in the past, and now she's able to take care of them. But the dentist is having trouble keeping the provisional on the second molar. Here's what the second molar looks like. What I want you to notice here is the amount of enamel visible. When we flap that open to do the crown lengthening, or as I actually like to call it, gum shortening procedure, because that's really what we're doing, we see lots of bone. This is a problem of bone. You may think this looks like a problem of gum, which it is, but it's there because of a problem with the bone. So that's why the first thing that I said was bone to restorative margin. And maybe some of you humored me and wrote it down. So after the bone is recontoured, see, flattened out, gone. These lumpy things gone. Some contouring then, scalloping the bone around the teeth makes this tooth restorable because we've exposed some healthy tooth structure. So you can get a sense here about why the provisional wouldn't stay on because the buckle's pretty well shot. But after the contouring, we have tooth structure available. We can do the buildup like you saw with Danny Melker, and we have solid tooth structure. And look on the lingual, how much more tooth structure compared to before. Maybe half the enamel is visible. Here you see double or even triple the amount of enamel plus other root surfaces. Better retention is possible with this procedure, and the crowns can be put on without having to reach up under there and impinge on the gum tissue in any way. Restorative challenges. How about in Mark's case? Would you do a gingivectomy here? Because the dentist, the referring dentist said, I really cannot get impressions here. So could you do just a gingivectomy? It's tempting, isn't it? Look at the gum here. Look at how much extra there is. It's kind of over the occlusal surface, is it not? That's a lot of gum. Is that the problem? No, it's really the bone. And Andy's asking what I use for bone contouring. I use diamond burrs, diamond high-speed burrs. If you're doing these procedures and you're interested in the burrs, I get them directly from the manufacturer. And if you send me an email, I can send you their information. I'm happy to do it because I really believe they're high quality and really, really inexpensive. I've asked them to raise their prices. They don't do it. So diamond burrs, high speed surgical length diamond burrs. And here's why you need good sharp diamond burrs. This is what's underneath Mark's tissue. This looks like there's a soft tissue problem, but you see here, it's really a bone problem. And once we contour the bone, look at how much more tooth would be exposed. Look at the mesial. That the area that we couldn't even see here was all under the gum is visible. You can prep. And there's enough tooth structure that you can even do supra-gingival margins. So I totally believe in that. So that's ways to solve restorative challenges. Also, I said it would solve aesthetic challenges. So this dentist, Neil Shaw, is a member of the Texas AGD group. And I presented to them several years ago, pre-pandemic. And the way their group works is they hear a clinician, and then 9 months later, they reconvene and they share the cases that they did on the topic that they heard 9 months prior. Just turned out, by coincidence, I was in the state of Texas for a class beginning the next day, which would have been Friday. So I went a day early and I attended their session on Thursday. I want to tell you, it was one of the most memorable experiences of my life, because here are these people all presenting cases on the topic that we did 9 months ago. Now, not all of them, matter of fact, I would say probably half of them did not do the case themselves. They still referred it out. But they all said, well, I learned a lot. I got the diagnosis and the treatment planning and the indications and the limitations so I could make an informed referral. I mean, I was really touched. Then Neil comes up and he says, you know, I felt the same way. I was going to make this referral at the last moment. I said, no. There was a case very much like this that Jim showed in the class, and it showed gum hanging low on both sides, and it looked like I could maybe do this. So I decided to do it. And this was his very first case. He shortened the gum, and look at the nice aesthetic result he was able to achieve. Touches me. I'm not kidding. I was really touched. So it made me feel good. Now we can also get some improvement in anterior aesthetic regions by understanding the same thing about bone contouring and understanding the principles of biologic width. Many of you might say, well, yeah, this looks familiar. This description of biologic width looks pretty familiar. And it's very common to see a diagram like this. The problem with this particular diagram is that it's wrong, and as the slide says, oversimplified. Now, all the diagrams that you'll see probably share these numbers. These are the numbers for biologic width that came from an article mid-1960s, Chicago colleagues, Gargiulo, Wentz, Orban. The Orban name might sound familiar. That was actually his father, the famous Dr. Orban. So these three colleagues got 150 or 160 skull specimens, and they measured the dimensions of the human gingiva. So at the end of the article, they said we got 4 stages. We took very young, like a teenager, young adult, on and on and on. Stage 4, a more elderly person, had different levels of recession in each of these 4 groups. And then they said, so if we take all these groups and average the dimensions together, we end up with this number of average dimensions. It turns out that conventional wisdom looked at that and said, well, you know, those numbers are hard to understand. Let's just look at this as all 1 millimeter dimensions: connective tissue, biologic width, sulcus. So that in their article, it actually reflects that 3 millimeter dimension, because from the tip of this bone right here to the tip of the gingiva right here, 3.06 millimeters. So it's fairly reasonable to say each of these is a 1 millimeter dimension, and it helps us. Why does it help us? How does it help us? In case you're wondering, why am I even giving you an academic, didactic concept that might even be confusing? Well, I'm doing it because if you can grasp it, and I'm sure many of you have and do grasp it, then it will guide you in where to place your restorative margin. Because you see, you know where the bone is because you can feel it under anesthesia You can probe through the tissue, boom, you hit the bone. Typically right here, 3 millimeters. You can see where the gingiva is. But what do you not know in your assessment of biologic width dimensions? You don't know and can't feel, and there's no way to assess where is the end of the sulcus. Because if you probe in here, you're just going to go into the soft tissue. And the patient will jump and you'll say, oh, okay, well, that's the end of the sulcus. Well, is it? And if you're under anesthesia, they won't jump at all. Well, we go back to the 0.7 of a millimeter. This may be your safe playing field where to put a margin if you want it subgingival in an aesthetic zone or any zone, that you have a 0.5 millimeter playing field here, which is a safety valve for avoiding going into the epithelial attachment. If you're wondering, so what happens if I do go into the tissue? Well, here's a couple examples. Here's Jill. What she had was gum tissue that was down low. So the dentist, she didn't like the short teeth, and the dentist did an electrosurge gingivectomy. Gums went higher, and the crowns were placed higher. But what happens? When you cut the gum off, it wants to grow back, and it wants to reform that same 3 millimeter biologic width. Here's another example, Dara, who has a high smile line and was really upset by this. Same story, laser gingivectomy, tall crowns placed, gums grew back. Hers took a little longer. Gums grew back. And look at the swelling, the redness, the thick margins compared to this young guy with healthy gingiva, pink, stippled, knife edge. You can't just do a gingivectomy without bone recontouring or the gum will grow back. It might take a while. There was a study in Italy where they did this on a number of patients. It took 1 year for the gum to grow back when they cut it off right at the edge of the bone. It took 1 year to develop this 3 millimeter biologic width, but it does redevelop and it does grow back. So John Coyce, Pankey and John Coyce, they're my two heroes. I took a lot of classes with John Coyce where I learned about these dimensions. And he explained, I said one day, that's a nice presentation. He said, oh, well, you understood it. There are plenty of people leaving this room that have no idea what I just said. And I understand that because the very first case I did, after hearing him, I did it wrong. I did it wrong. But believe me, I learned from that case, and I won't make that same mistake again. What John did was he measured 1,000 patients in a row, consecutive people in his office, and he measured the dimensions of the human gingiva, and he found basically that probing from the bone crest under anesthesia again is reliable. Biologic width is not some contrived notion, as some people might believe. And what he found for the most part was 3 millimeters on the buccal and 4.1 at the papilla and the anterior and the central area. So these were reliable measurements. So how can we use this biologic width information to restore teeth? I hope that makes sense, how you can use it and understand where the margin it goes, where the sulcus is, where the bone is. So I hope that maybe it's starting to make a little bit of sense as we look at Dr. Pankey's cross of dentistry, that I'm guessing some of you may have explored this journey already, where you know yourself and what you're trying to achieve, and you understood his list of 21 questions. You may have your own list of 21 questions to get to know the patient. You're here tonight learning a little tidbit about knowing your work better. And if we can combine all this, I hope that you can take what I'm sharing with you today to apply your knowledge, because as you can see, I'm very committed to this topic, passionate about this topic. I'm happy to say that it's a popular workshop when I do it on the road. Here's an example from John Coyce to help us further explore and understand the idea of bone affecting the tissue. So John's talking about asymmetric bone versus symmetric bone. See the difference here? Symmetric, asymmetric. And what he's explaining in this particular article is that the bone drives where the tissue is going to be. And he talks about how to manage it. Well, here's a perfect example of how to manage Valerie. Valerie is in her 40s. Her father was a dentist, and all through high school and college, she wanted to correct this because she said it kind of bugged her that she had this uneven area, and he, bless his heart, had no idea what it was or what to do about it. Well, now she's in her 40s, and she decides to take it into her own hands and goes looking around for a dentist that understands this, ends up being referred to me. How do we correct this? Question. You're going to have to share this with yourselves. If we were live, I could see how you're doing with this. I would explain as follows. We're probing under anesthesia, and we get a 3, 3, 3, 5. It's different. 3, 3. So if this is a 5, can you all picture in your mind that the bone is up here, 5 millimeters? Now here it was only up 3 millimeters, but you see the difference in the tissue? So if we've got a 5 here, I hope it's clear that you understand that you could gingivectomy away 2 millimeters. Now Dara and Jill couldn't because their bone was not up here at 5. Well, actually, what if Valerie's was not at 5 either? So if we probe it, we get 3, 3, 3, 3. Can you picture in your mind that this difference is at the bone level? And that if we want to correct it, we have to correct it at the bone level. So doing that leads to Valerie being able to have symmetrical gingiva. And you can see with the high smile line why it's always bothered her. Really satisfying to be able to do these kind of things. So we got a little off the topic of just saving teeth, but we could look at this and say, are these teeth really hopeless? Or is there a chance that they might be treatable? Where not everybody would agree, but maybe they're treatable. And I'm saying to you, yes, I think they are. And hopefully, after a few more minutes together, you'll get a sense that understanding biologic width, understanding what's savable and not savable, understanding where there's potential might deliver more teeth instead of more implants. So here's an example. Now, every patient, practically every patient that I see with these problems, literally have the exact same red flag stories. I mean, exact same. They all say, ever since I had this bridge or this crown, my gums hurt, or my gums are red in the case of Jill and Dara. Ever since I had this crown or this bridge. So does that make sense to you that this could be happening? It should. And what I said earlier is I want you to be able to get a sense from the radiographs. Look at this radiograph. Something funny right here. Yeah? Something funny with this open margin. Something's off with this. Can you solve this problem? Is it hopeless or is it treatable? Here, folks, I don't know if you're taking notes. If you are taking notes, I think this is something that I would encourage you to record and be able to look at it later. What you say to Lisa is, she wants a new bridge. Can you make me a better new bridge? Yes, I can, but there is a chance you, Lisa, will need a surgical shortening of the gum. And I won't know that till I get your bridge off. Now, everybody, you win 100% of the time. Because if she needs it, she'll say, oh, well, I didn't really want it, but okay, I'm glad you told me I might. So I appreciate that. Go ahead. And if she doesn't, she'll say, oh, great, I'm glad I didn't need it, but thanks for your concern that I might. So you win every way. Every time, each way, you always win by telling someone they might need a gum shortening. Because when you get this bridge off and you see this is the abutment. Now I'll tell you about this dentist because I knew him. He was proud of his buildups. This is his buildup, composite squished underneath the crown when he puts the crown on. Embarrassing, this not our core values, not my core values. So we can go ahead and we can treat this and we can expose more tooth. We have enough tooth now. This is the original bridge. We use this as a provisional because it came on and off so easily. We can take away the gum and the bone, like you saw earlier with Beth, with Danny Melker's case. There's more tooth structure available, as bad as it looks here, so that a new restoration can be made easily and predictably. So can we save more teeth? If you had doubts about that one, I hope you see the answer could be yes. Jane has a red flag story. They all have almost the identical story. Ever since I've had this crown, my gums hurt. Can you make me a better crown? And the answer is yes, Jane, but we might need a gum shortening procedure. So you tell her that ahead of time, because if you don't tell her and you go ahead and take that crown off, you say, oh my goodness, Jane, I had no idea. There was a missing tooth here. This tooth is tipped over. The top of the tooth is actually under the gum. I cannot make you a better crown. You need a surgery. She says, hold on a minute. You told me that you can make me a better crown. You never mentioned surgery. And you know what? Jane would be right. So I'm giving you a little hint. Say that to everybody. And then it's not a surprise. It's typical to have bone up there. 79% of people do. We can take that bone away, like you saw with Beth. We can scallop around the teeth. We can expose tooth structure that now can be predictably restored. So Yen is asking about how do you deal with a furcation? You deal with it. You almost can take these two roots and treat them as two individual root teeth, and you scallop each one, going up and over the furcation. I'm looking at my sheet to see if I have an example one, and honestly, I'm not sure, Yen. But yes, it could be handled by treating that scalloping over the furcation. And Andy's asking if there's a difference between a single crown versus retention tooth for a bridge as far as the depth of the gum shortening. I don't see a difference. I mean, we still need good retention. Like in Susan's case, she lost that posterior bridge. You know, the bridge abutment decayed out. Maybe it didn't have enough retentiveness. So I've never thought about having a difference between a single crown and a bridge. Just good retention. The minimum, this is something for you to keep in mind that would answer your question. It's the way I agree. The minimum amount of tooth structure that you need for a stable retention is 2 millimeters. This is out of the gum, outside of the gum. Here's the gum, 2 millimeters sticks up. Studies have shown that, studies at dental schools, 2 millimeters minimum, that's called feral. So thanks, Ian, thanks, Andy. These are questions that are worth asking, and I hope that I make sense, even though, as you can probably tell, I'm trying to keep the foot on the pedal to get through here in an hour and give you all time to pop some questions in. So I don't mind the questions now. When I see them, if I can do it and it fits what I'm talking about, I'm happy to do it. Okay, save more teeth. That is definitely my soapbox. Radiographs, point number 2, have a lot of information. As I said before, a lot of information. So let's look, radiographs. Larry, same story. Ever since I had these crowns made by gums hurt, can you make me better crowns? Well, I'd like you all to be able to take a look at this now and say, wow, there's something off about this radiograph. What's off? Very short crown from top to bottom. Are teeth crowns that small? No, they're not. Look at here, there's enamel that never got included in the prep. We're way far away from the bone. Here too, there is enamel. I guess I covered it up with the arrow, sorry. And you can see open margin there, open margin here, short, short, short crown. What's going on? Too much gum because there's too much bone. And so these are not normal looking teeth. But the clinician who did this knew that he had pretty short teeth. And in order to make sure the crown stayed on, he put a lot of retention grooves in, which worked. It stayed on, but look what it did to the tissue. Sore from day one, Larry said. And here's what those preps look like. I don't know if you agree with me, but it's kind of short on tooth structure. And so he reached under the gum, he or she reached under the gum to get more retention. And as a result, irritated the tissue because they got too close to the bone within the fibers of the biologic width. So we take off the crowns, go into this more in my workshops. I can't obviously go into the technique too much tonight. Take off the crowns, we put on provisionals. So let's say you do that, and Larry comes back for a post-op check in 2 weeks and the tissue's healed. Now you say, oh my gosh, maybe Jim was a little too vigorous about this. Don't lose the faith. Because what's happened here is these provisionals did not get down under the tissue as much as the crowns did. However the person got it to go under the tissue, these don't. So you can see that. There's open margins with all these provisionals. Look at here, and look at this huge open margin here. So these crowns did not go down far, and they did not impinge on the biologic width. Instead, you can see how the preps here, and even here, look, that's almost touching the bone. Touching the bone. Clearly, these preps, right here where the arrows are pointing to, are violating the biologic width because they're closer to the bone than that 2.5 millimeters we talked about before. How do we manage that? Well, we want to control the bone to restorative distance. Bone to restorative distance. Joanne, I have no idea what to do about the message I just got from you. I'm sorry, it's just not something I'm familiar with. So we're correcting the bone to restorative distance, creating more tooth structure, and now we can re-prepare these teeth. We can go again supra or sub or equigingival, whatever you prefer to do. And yes, anonymous attendee asked, what about the interproximal bone? Has to be removed, will cause papillary recession? No. I'm going to answer that with a no, but yes, we have to do interproximal bone reduction many times as well. And I'm pretty sure my very, very last case will illustrate that beautifully. But here we absolutely have to take bone down interproximally. And yes, there will be black triangles here, but as you can see, when this is all healed, these crowns will then become bigger than these provisionals are, and that will fill in with porcelain the interproximal. So that's why we need to wait a good number of months for the tissue to develop. And if the bone's in the right place, here's the key. Biologic width tells us the tissue will develop 3 millimeters. So you wait that out for a while and you can probe it and measure it. Yeah, you know, it's 3. I think it's stable. And now you can restore and fill in these black triangles interproximally. So this is what we had the day of the surgery. Short teeth, retention grooves. This is what the dentist shared with me on the day he was re-preparing. Look at, he's got all supragingival margins. No need to reach sub-gingivally anymore. No need to irritate the tissue. And he's got this from beginning, uninformed clinician, different set of core values, to someone that understood biologic width and even could make supragingival margins without impinging anymore. All right, it looks like we're doing okay with your questions. I can't imagine how many of you come later. So I'll try to get through these last few cases and then we'll open it up to some questions. I enjoy Dental Town magazine, and they put in it some of their discussions from their, I don't really know what they're called, bulletin boards, where you can put a question up there, say, hey, everybody, what am I going to do with this case? And you get responses. This was one of them. So I wait till it's in print. I don't hardly ever go online. And this dentist was saying, this bridge keeps falling off. Anybody have suggestions for me? So they got ideas for redoing the bridge, different cement, different occlusion. Maybe the occlusion's a problem, someone said. Maybe add another abutment out here. Nobody mentioned crown lengthening. Now, I wanted to, respond, but I said, I don't really want to, because my signature says I teach these classes, so I want to stay out of the discussion. So we have to make assessments. Are these teeth savable? to answer the question somebody's posting, when do you recommend extraction? Well, let's see if we can make sense of it as we look at these radiographs. All right, I already showed you one with Susan with an upper molar. There was a very short root. If we took bone away, we would have very little holding that tooth in. So that was an extraction. I'll look for some others. These are probably all examples on how to save teeth, though. All right, so there's my idea. Now, what do you see on the x-ray? That's my question. What I want you to see is this is not unlike Larry. This shows the crown margin way up here on the distal. All this enamel is not included in the prep. Why? Too much bone causing the gum to go too high, like a turtleneck around the teeth. This is classic gum shortening territory. This is a bone problem. This has nothing to do with the gum, even though it's the gum that's in the way of preventing this person from getting his prep down here and would have more retention. So here's another classic example. This is what I see. Beth says, I want another dentist. I want a referral. Why, Beth? What's going on? Well, she came from Florida out to Arizona when I lived there as a grad student. And she said, I just had this crown made at home in Florida before I moved here. And this dentist by the university says that I should have it removed and a new one placed. And that upsets me. Well, I looked at it and we have the classic signs of too much gum and too much bone. The gum tissue is too high here. The crown margin is high here. Look again, enamel, open margin on the mesial. What's going on? Without looking in her mouth, what's going on? Too much bone, too much gum, high turtleneck. If we shorten the gum, you can see here, more tooth structure available for a better retentive crown, whether this be a single crown or abutment. I think it would be treated the exact same way. It's actually easier to do teeth that are standing alone abutments because you don't have teeth in the way. So yes, very treatable. Remember, in my own silly way, that if you think today the way you thought yesterday, you could be left behind tomorrow. So it was my job to help you with your thought process. I hope I did a good job. I hope I did a better job than whoever was supposed to pick up this critter, because I don't know whose job that was. I know what my job was, and I hope I made some sense in the time allowed to give you an idea of a concept of saving more teeth and learning a lot of information from the radiographs. Those are my two goals. Closing thought says that it is indeed a privilege. I was lucky enough to go to the Pankey Institute somewhere around my third or fourth year in practice many years ago. It's meant a lot to me. It's changed the way I practice. It is an honor and a privilege to be here to share this information with you. It's my favorite topic. I think it's meaningful. I congratulate you for picking this topic, and I challenge you to think about the radiographs, think about ways that teeth that look difficult, like Danny Melker's molar or Beth and some of the people I've showed you. I challenge you to look at those and encourage you to consult with somebody if you need to see if, in fact, these teeth are treatable. So hopefully you can do this and save a few more teeth.